Welcome. This best practice brief is a partnership initiative of the South Dakota Foundation for Medical Care and the Great Plains Quality Innovation Network. My name is Stacy Fredenberg, and I have the pleasure of working for SDFMC and supporting the work of the Great Plains Quality Care Coalition. Before we begin, we're just going to go over a few housekeeping items. This session is being recorded, and it'll be posted on the SDFMC website on the best practice briefs page. All lines are being muted throughout the session, so please add your comments and questions to the chat box, and we'll answer those at the end of the session. While most individuals work to avoid emergency departments, others consider it a source of primary health care. So when emergency services are overused, the cost of healthcare increases across the board. The series that we've been doing on Care Connections has been exploring the strategies for encouraging proper use of emergency departments. Today's speaker, Ashley Kingdon-Reese, is going to focus on opening doors to improved mental health. Many individuals with mental health issues have faced a closed door to services and instead may turn to an open bottle. Whether that's pills or alcohol, their unmet need for mental health services may escalate into substance use disorder. Angelhaus Huron offers an open door transitional center to help individuals cross that final threshold from treatment to recovery. So thanks for sharing with us today, Ashley. I'm going to turn it over to you.
Hello, thank you for joining. It's great affinity. I hope we open this conversation and discuss how we can evolve and introduce and begin to look at best practices. We're going to talk a little bit about emergency rooms, but the reality is if you're joining this series, there's a reason. You have seen the impact of mental and behavioral health in whatever role you're in when it comes to healthcare, whether it's an emergency room, or OB, clinical setting, or assisted living, telehealth. We are seeing the numbers increase. And with behavioral and mental health comes substance abuse. And a lot of it is due to the individual's desire to escape or self-medicate or to find a quick release from what's going on internally. So as we talk through today, if there are questions that come up or concerns that you have, please add them to the chat room or raise your hand and Stacy will make sure we get to them. The purpose is to explain the challenges in maintaining mental health for individuals that are transitioning from substance abuse into treatment. We want to describe how this transitional housing that we have started here in South Dakota was developed, where it came from, and identify the efforts to expand referral and reinforce ongoing recovery. Believe it or not, this epidemic and pandemic of mental and behavioral health has really been exacerbated with COVID. And I'm sure you've seen it personally. And so as we're trying to catch up in the healthcare system to figure out how to best triage and treat this demanding need, we're going to need your help. So identifying ongoing efforts that are already in existence is important, but creating tools in your own industry is also essential. So we can reinforce and make sure that we're evaluating the outcomes. We want to be able to introduce best practices that can make your role, no matter what it is, whether you're an exec or a manager, a director of nursing, or providing direct patient care to the individuals presenting in your department. We want to make sure that we're giving you tools for your toolkit going forward. So Angelhaus Huron is a group of assisted living that started first with memory care in Aberdeen, South Dakota, and has spread to Yankton and now to Huron. And the unmet need that was identified is a group of individuals. Think of your vets or middle-aged people that aren't old enough to be in the nursing home, under 72, and possibly have some medical or physical impairments, but their underlying diagnosis is behavioral health. And so what we offer at Angelhaus is an assisted living, and that's what we're licensed under. So the 24/7 care that comes with all of them with a registered nurse in charge. They all have private rooms because, as you can imagine, a shared room with behavioral health needs can lead to complications. We have behavioral health aides and community health workers, which if a lot of you joined last week, got to learn about that role. We offer AIDL assistance, medication management, activities to encourage mental and physical well-being, and for them to help find purpose, because we've identified that that's some of the barriers that they're trying to overcome with their recovery. Of course, personal laundry and housekeeping are provided, and some other amenities like Wi-Fi and DirecTV. We partner with community counseling. We do nutritious meals because as you learn about behavior and mental health, nutrition is essential, either because the medications they're on and what it does, it depletes them physically, or to help avoid complications. Supervised transportation, individual plans of care, registered dietitians and consultants. We do daily crafts and activities to bring them part of the community. We also have complimentary payee services and any personal care products that they need, we provide. So what Angelhaus really was born from was this middle group that were too young for a nursing home and frankly didn't fit that mold. They were either placed there early and continued to, the call like queens, calling people in to where the staff could no longer care for those that had physical impairments. And so we looked at the demographics and decided there was a way to do this with an open door setting. We partnered with Lewis and Clark initially in Yankton and provided that second step after their acute care stay with HSC. So when they come to us, we really use Maslow's hierarchy as our guide. Some of them come in from the criminal system. Some of them come in from a detox setting. Some of them come in homeless. And so really finding out how we can help them best navigate and get to those level of unmet needs with some assistance, so they are productive members of society. So today as we move through, I'm going to try to be effective, efficient, and compelling, but I'm really looking for feedback. Some of the slides I have on here are really for your reference, as you will get a copy of them and can use them as you're trying to develop tools or find best practices for your unit. To be clear, I thought we should define some terms. There's a difference between behavioral health and mental health. Mental health is really our feelings, right? You might be sad, you might be depressed, you might be happy, you might have anxiety, but it becomes behavioral health when there's an action related to it. And more than just an acute one, a chronic stage, and usually we look at longer than 6 months, where the behavior is coming from a mental health undiagnosed or untreated condition. So for today, we're going to define it a little deeper. Mental health refers to a person's emotional, social, psychological wellness, and it affects how we act, how we relate to others, and how we handle stress. Major factors that can contribute are biological, their chemistry makeup, their genetic, their life experiences, their trauma, abuse, family history, culture, and mental health problems, like head injuries. Mental illness, on the other hand, is a condition that refers to a disorder in an individual's mood or behavior or thinking. Mental health disorders include anxiety and depression that are a chronic state, schizophrenia, eating disorders, and addictive behavior. So at Angelhaus specifically, we're not looking at diagnosis. They've already been treated, diagnosed, and are on some kind of medication that's going to help them with their mental illness or their behavioral health. Behavioral health includes substance abuse. It includes eating disorders, gambling addictions, domestic violence, sex addictions. And each of these conditions actually stem from destructive behaviors or a mental health disorder. Behavioral health disorders involve a pattern of disruptive or destructive behavior that lasts several months or more. And it isn't a spur of the moment action, but rather a pattern that's built up over time. So one of the first things that we're going to talk about is how you identify those patterns when they present to you in the emergency room or clinical setting. And if it becomes what you recognize it is a behavioral health disorder, professional behavioral health services are needed to help this patient overcome the disorders and behavior. And frankly, stop them from breaking the system and the payer sources that are struggling to keep up with the demands of behavioral health. So what we've learned through data that's been collected, these key points of interest, are positive outcomes that are experienced by individuals who actually receive publicly funded behavioral health care. Mental health and social well-being, increased ability to control the substance abuse, whether it's illicit drugs or overuse of medication or polypharmacy. Increased motivation to not use substances at all that aren't prescribed to them or use them in the correct way. The most important thing is fewer high-cost services, meaning they're not presenting to the ER, as you heard in the intro, as their first and foremost line of defense for care. This affects all of us in the healthcare industry. And this is what we're going to focus on now. So we won't go over one of these slides, but I want you to have them for reference. The South Dakota's statistics on families that were served by the system of care, 2,000 youth benefited from the services they had last year. 729 families reported being serviced by the service of care related to behavioral and mental health. So knowing that this data comes from the families that reported it, it's really good to reference and look at. It's really good to understand their point of view and how when they get to the right resources, the numbers decline. 92% of decrease in number of emergency room visits for psychiatric or emotional problems. 92% decrease once we got them to the resources they needed. Over 40,000 hours were spent in emergency services provided through the system of care, and 4,613 emergency service contacts. These contacts are made to be defined as anything from setting up appointments, being a liaison, collateral contacts, telephone reports. But again, this is what we know about. And what we're trying to gather is how big the problem really is so that we can combat it, divide and conquer. Because this is what we're learning from the families, not from the providers. This slide really goes into the data collection process, and you'll want it for your reference. It explains what they did and who they looked at as stakeholders. They explained what surveys they used, but more importantly, how those surveys and the data they collected was done. So, for example, the surveys that they sent out were optional. And a lot of the clients that completed the surveys didn't finish them or answer all the questions. And so as we walk through this, I'd like you to open up a little bit and open your mind to think of how we can get more inclusive data from the provider's point of view and to get these surveys to where we have a full collection process and look at different agencies. So this slide is really, again, for your references and talks about additional tools that were used in collecting this data. So what is your call to action today? Why are you here? The goal is to identify and develop professional roles to contribute proper emergency room utilization related to behavioral health treatment. And if you were on last week's series, you learned a little bit about what the community health worker does. I can tell you from experience, whether it's sexual assault nursing examiners or executive nurse groups or American Nurse Association or any of the medical subgroups that I'm involved with, bipartisan, nonpartisan, it is an urgent call to action. We are looking to identify and develop roles that can enhance both the nursing and the clinicians to help reduce this stress and to get those individuals to the care they need as quickly as possible. This also involves utilizing existing resources for prevention and education programs to improve care coordination. Get familiar with your community. Know what resources are available. In Huron, we use community counseling. We have a wonderful relationship either with telemed or case managers, and we work really hard symbiotically to make sure that the needs are met, because it became very clear after opening Angelhaus that one agency cannot service the layers of need that happen for these individuals that are struggling with substance abuse, mental health, and subsequently behavioral health. We want to highlight, implement, and model best practices for improving healthcare navigation related to unmet behavioral needs, because there are tools that are out there. And we may not have to reinvent the wheel, but just recognize where they're at. We want to create and implement and utilize data-driven tools specific to each point of care that address the end user's pain point, and build interdisciplinary collaboration with community members to enhance best practices. And we're doing that today by having this best series and learning more about how we can communicate, collaborate, and learn from each other. Some of the effective tools to quantify and qualify are initially assessments. We are in such a, Stacey and I were just talking, in such a technology driven world that we go to click buttons. All of our assessments are there. And it's quick and it's easy and it's really essential when we're trying to get down and dirty and make sure that we're meeting their needs, especially in the emergency room, emergency department. Take a minute and make sure that your assessments incorporate behavioral mental health, that you're able to identify and quantify patterns that you see, and that your assessments allow for open-ended questions that may not be able to be defined in a box or yes or no. Understand that medication education is essential to recognizing patterns and clues that indicate there is an unmet mental health need. Even if you've got nurses, it's important that run your department, it's important to have information available for them so they can recognize these medications when they come in, some of the side effects that happen with them, and some of the reasons why they are being prescribed. Oftentimes, prescribers use medications for off-label reasons. And so opening up that medication list and looking at what could be interfering or why it was prescribed is essential to getting them to the resources they need. And developing collaborative teams to assess and evaluate the outcome. Through this series, we've learned about different roles, power of Narcan for those that are using opioids, and how the laws are changing to support clinicians and caregivers to best meet the needs of mental and behavioral health. The value of behavioral health assessment tools helps not only in the moment you're there serving the patient, but going forward. It helps in better screening and early intervention to lead to better outcomes. It helps standardize emergency department behavioral assessment tools and primary care providers and helps spot signs of mental illness that maybe isn't diagnosed. It helps standardize behavioral health assessments for important measurements in research and training the next generation of healthcare providers. It also can point to effective treatment plans to track patient progress so that we can evaluate what's working and what's not. It's not when or if this behavioral and mental health pandemic is hitting us. It's now and it's here. And preparation is essential. So as the clock ticks down and we see a nursing care shortage, and we see payer sources dwindling, and we see burnout on all levels, it's important that we practice and report and plan for immediate interventions and work together to find these outcomes. Don't worry, help is here. Just recently, the National Institute of Health now requires that articles published are freely available to the public. And they have wonderful resources for assessment tools and trainings and webinars that you can use. And so I put these in the slides so you can click on them and find what works best for your department. It's important when you're looking at tools that maybe if you don't find one that's on the National Institute of Health or the National Cancer Institute, which has done wonderful research for behavioral and mental health, that when you're adopting these behavioral health assessment tools, there's certain qualities that are important. You want to make sure it's clinically validated, that it's accurate, that it's speedy in the sense that you're not going to bog down your department by trying to go through an entire 15-page narrative. The faster the completion time, it improves the patient's experience and helps healthcare providers arrive at an accurate diagnosis quicker. Digital always helps until technology fails you. But the demand for virtual behavioral healthcare is high and it's growing. And there are many digital mental assessment tools that support a virtual patient care experience and can also help the clinician move quickly through that diagnosis and assessment. You want to make sure that these tools gain reimbursement, that they are reimbursable, the primary care or the department that you're working in. For behavioral healthcare specialists, making sure that you can bill for the behavioral healthcare is an important consideration for your profession, your role, and the systems we work for. You want to make sure that these tools are comprehensive. Rather than relying on multiple screening tools for a diagnosis, it can be really helpful to use one single tool to evaluate many possible disorders. And as reference, excuse me, the DSM-5 will help with behavioral health assessment tools. It should meet the standards for this. The Diagnostic and Statistical Manual of Behavioral Disorders, there's a 5th edition now out, categorizes and explains both how they can appear, what we're looking for in diagnostics, and is part of the American Psychiatric Association's authoritative guidance on behavioral health disorders. The final thing that you want to look for your tools is that they're independent, that they're not produced by a drug company, right? That they're not from a specific entity that gains financial status by using them. You want to be aware of who created the screening tools and assessments that you are using, if there could be any bias, and if they're going to work in the right environment that you're in. So as the final slide, I put some resources in here that you're able to look up to find the data that I included. That South Dakota did a wonderful job at looking at youth risk behaviors, because mental health really starts in children. Understanding how to deal with emotions, anxiety, depression, fear, loss, all incorporates how they will grow up and what resources they may need if they aren't met. So use these resources to find out what we're looking at now and how we can best combat them as a state together. I really would like to open up these doors to exchange numbers and to figure out how we can collaborate together to see how you can find resources when there are no others. You might have somebody come to the emergency room that comes in homeless or looks disheveled or isn't acting correctly. And you don't have a lot of time to figure out where we're going from here. But remember that stop in the emergency room, maybe their first or their last on a journey to getting their unmet needs taken care of. And together, we can help make sure that we're doing this so that we have enough providers to carry on to the next generation, enough resources to share with each other. And hopefully together we can figure out the best practices of how we can get these behavioral health patients in the right places. I'll open it up for questions now. I'm hoping to get some feedback and answer questions directly that you might have.
Thanks, Ashley. Can you, first of all, feel free to add comments and questions in the chat, or like we said previously, if you want to ask your question out loud, you just raise your hand and I can unmute you so you can ask your question to Ashley. But can you talk a little bit, Ashley, about how are you integrating with the healthcare facilities in Huron and the Human Services Center so that when people are using those tools and assessing and screening and getting them through the treatment process, can you just explain how that collaboration works for you?
Absolutely. So we started by meeting with community counseling, and we have a crisis intervention group that is made up of sheriffs, social workers, community counseling, volunteers, our state's attorney, and really looking at what our community needed. And again, it was apparent to me working in home health, seeing individuals that didn't really fit into a nursing home. And even though their medical needs were being filled with home health are being met, whether it was, transferring or medication assistance or blood pressure or diabetes, there was still another level of care that was affecting their overall medical being. And so we partnered with CCS and looked to Lewis and Clark to find a model that worked. In our community, there was a place called Bradford Leary for years that worked as an apartment and people lived there. They closed that model. And so they're back in the community instead of living under one facility and one roof. And so our first step was to see how many people that we knew or could account for that would benefit from having an assisted living setting. So to be clear, we're licensed as assisted living just like anyone else, but our target market is behavioral health. And so it took us meeting with the clinics, the hospitals, Lewis and Clark, and CCS to really identify how best we were going to service these individuals. I always say it's not like mermaids and unicorns, that do they exist or do they not? These people do exist. And so our goal is to keep them out of the overcrowded prison system, to keep them out of early, admittance into the wrong care setting, like a nursing home, to keep them out of your backyard, to keep them off the streets, especially when we're looking at people like the vets that served our country and came back needing our help. So when we partner, it's a community-wide thing. Even Salvation Army, we get vouchers from them because some of them, when they start day one, they have a pair of shoes and the clothes on their back, and that's it. And so really looking at Maslow's and seeing where we are beginning with them. Is it safety? Is it those basic needs like shelter? Or do they have those things like clothing? And now we're moving on to the next one, is their social norms. What do they have for natural supports? A lot of the people that we get are Native Americans and come from reservations. And once they leave that setting, they don't have a lot of contact with their family. And so, going back to their leaders, their tribal leaders, and figuring how we can get support from them or reintegrate them back into their culture, or those things that we want to pay attention to while they're staying with us. Initially, when we opened, we were looking at a permanent solution for assisted living. And what we found is we've had about 17 in the short time that we've been open that have successfully returned to being productive members of society, holding a job, paying bills, remaining on their medication, staying in counseling, and have successfully gone through the program.
So would you, when you have people come into your facility, are they all referral based, or can people admit themselves or like refer themselves to your facility?
Yes, we have a lot of family members that contact us that say, listen, I can't, I've got caregiver burnout, that he was in a Vera behavioral for a while, and he was returned home, and his needs far outweigh what we're able to do. And so that call, we call them the decision makers, meaning they're the person that decided this person needs more help than what they're getting. So those decision makers may be family members, they might be neighbors, they might be church clergy, but they're not, oftentimes it's not the user who is the recipient of our help or the resident once they become admitted. If a family member is the person making that referral, of course, we circle back around to the clinicians that are involved in their life, whether it's the clinical or if they're getting help through some psych services or the VA, but it can initiate from anywhere. We've had referrals from all over. And sometimes it's just a cold call saying, listen, I got your number from a counselor who knew about you, or my friend talked about you when she went to a meeting for nurses. Oftentimes they don't know what those answers are. They're just looking for any way to be able to help their loved ones get some relief.
So I see it's kind of, you have an integrated care service, because from my understanding, Ashley, and please correct me if I'm wrong, so you have a mix of people who are that younger realm who need that assisted living care, and then you also have people who need additional behavioral help assistance. So are you combining that in your setting?
No,
Oh,
Angelhaus
okay.
Huron is specifically behavioral health. The
Okay.
other locations might have memory or more of the standardized assisted living, but
Okay.
here and the one in Yankton are specific to behavioral health. And so they need to be above 18, an adult, and usually up into that 72-year-old mark. We do have a couple that are a little bit older, but are in a good condition and don't require any hands-on assist.
Okay, so I just wanted to clarify so that I knew exactly the criteria. So we do have a question come through. How many residents do you have, and where do they come from in South Dakota?
Great question. So we are licensed for 45 here in Huron. Again, they all have individualized rooms. Before this, it was a nursing home. And so they were sharing rooms. And we found out very quickly that was not a good solution. They needed it. So we're licensed for 45. And at the moment we have 41. And so they're coming from all over South Dakota.
Mm-hmm.
I don't know how many people know this, but our state laws read that if you are stay the night, one night in South Dakota, you are considered a resident as long as it's not in a hotel. And so other states have gotten privy to this knowledge and began putting people on buses to come to South Dakota. And so oftentimes we'll get a call from the sheriff's office or the emergency room and said, we've got this person that showed up on our doorstep and they've come from Alabama or Georgia, and the system that they were at put them on a bus and send them to South Dakota.
Wow.
And so it's not just South Dakota people we're serving, it's all over. But to be more specific, a lot of native reservations, we deal a lot with HSC in Yankton,
Mm-hmm.
a lot with
Mm-hmm.
Avera behavioral, and really a lot with clinicians that maybe are seeing this chronic behavior come back
Mm-hmm.
in a clinical setting.
We had another person comment, say, great resources. I'm an RN, work as a telephone triage nurse. I've spoken to many families members desperate to get their family member help. I also have personal interest with a son who has alcoholism, schizophrenia, does not acknowledge his mental illness. In my job and personal experience, I've run into a multitude of roadblocks. Police have not been helpful on several occasions when they have been involved. And I think that's, part of what we're seeing is, like Ashley is saying, trying to find this way to coordinate between law enforcement, medical care, behavioral health, counseling, and the Angelhaus Huron and Yankton locations. Their solution is this transitional housing care facility, which is kind of a unique way to integrate medical and behavioral, make sure they're getting taken care of before they move on to that next step. That to me is like filling the gap of that kind of that period of getting back into the real world, because they can come and go still from your facility. Ashley.
Yes.
And
So
they,
it's an open door. And so, oftentimes it doesn't work for them. And the nurse that just chatted in, you're absolutely right. I don't know if it's because we don't have enough people to service, but by the time we get them in and set them out for even just a substance abuse assessment, the wait is 2 weeks. And in that meantime, they've broken windows and come home drunk and caused violence. And so we all know there's an alcohol problem. And so hopefully what we can do is create, an alert and raise our banners to say we need some more assistance and to look at this problem differently. I would love to be able to give you a model that says it works everywhere, but I've found out the hard way. The Yankton police who deal with HSC are accustomed to this. Mine in my city were not. They are now. And they've transitioned, but it's important that you as clinicians reach out and build those bridges. And it's hard to say. And I know that you feel like, you're burdened with all these other things, but the answers are going to lie with us, the ones that are on the front lines, the ones that are making the decisions, because it's breaking our healthcare.
Thanks, Ashley. We're at the bottom of the hour. It's just past 12:30. And so I just want to thank you again for sharing your experiences, your insights, and the great work that you're doing there in Huron as an example of an innovative solution. So this is the last of our Care Connections Best Practice Brief session. This recording will be posted up on our website, and you can find the link in the chat box. We love to share what people are doing in South Dakota as their best practices. So if you have an idea that you yourself, a best practice you have, or something you'd like for us to share, please let me know. I put my email in the chat box as well as a reference. And then finally, we do appreciate it when you take the time to complete our evaluation. We do use those comments and feedback to try to improve and advance our learning opportunities. So with that, I thank you all for joining and wish you a great afternoon. Thanks, Ashley, again.
Thank you. Appreciate it.
You bet.